Welcome to the Health Workforce and Technical Assistance Center's webinar series. This webinar is entitled Using Secondary Data and is the second in a two-part series on our Health Workforce Analysis Guide. It was presented by Robert Martiniano on December 7th, 2016. Hello, my name is David Armstrong, and I'm the Director of the Health Workforce Technical Assistance Center. And today I'm joined by Robert Martiniano, a Senior Program Manager at the New York Center for Health Workforce Studies. Today's presentation focuses on secondary data and is the second in a two-part series focusing on our Health Workforce Analysis Guide that we just released. The Health Workforce Analysis Guide, along with all our previous webinars, which are archived, are all available on our website at healthworkforceta.org. Now, after today's presentation, you may ask questions using the chat panel on the right of your screen. And make sure you send your questions to all panelists to ensure that they have an opportunity to be asked. And at this point in time, I'm going to go ahead and turn the event over to our presenter, Robert, and we'll go ahead and get started with the presentation. Thank you for joining me here today, Robert.
Thank you. You're welcome. Okay, so I wanted to start with just thanking some staff at the center who helped with this, including Rachel Carter, Jenny Gao, and Nafeen Haroon. They all worked on helping with these slides. So just a brief information on our center. You know, we've been around actually 20 years now. We're celebrating our 20th anniversary, and just some background on us again. So today's topics, we're covering the secondary data, and as David said, this is the second part of a two-part webinar series that talks about our data guide and how we use that for analysis. So again, we're going to focus on secondary data, and I'm highlighting 4 data sets, although we understand that there are many more people could use. So why do we use secondary data? We use it for cost, convenience. Somebody has expertise that we don't have, time, because we know that if we're doing primary data collection, there's time in terms of developing the survey, putting the survey out, and analyzing the data. Obviously, that if we're using data that somebody's already collected, we're going to be saving our time and our costs if we're not having to do mailing. So as you know, going past time, cost, and convenience, you've got to think about your secondary data set. How old was it? When it was collected? How big is the sample size? Does it make sense for what you're trying to do? And along with the age of the data, you also have to consider different interventions that may have happened during the time the data was collected. So for example, we track licensure data, and in the mid-1990s in New York, they actually changed how pharmacists were licensed. All of a sudden they required, not all of a sudden, but they required the Form D. And what we saw with the licensure data was there was a drop in the number of pharmacists licensed. So, you know, again, as you think about the data, always consider other events that may have happened that's going to impact on how you understand the data. And finally, and I don't want to belabor this point because I think that everybody knows about this, but, you know, whether the data's been cleaned, do you have to do things with the data? So secondarily, you know, as you're thinking about the secondary data, who's collected the data? Did government, did researchers, did advocacy groups? You know, at times that advocacy groups will collect the data to try to promote an agenda. So there may be an inherent bias in either how they collected the data or how they're presenting the data. So you always have to think about that. Additionally, you want to think about how questions were asked. So there was one survey that asked RNs how dissatisfied were they with their nursing position. It's a leading question. It's problematic. It puts evidence into information that's not necessarily there. So we always have to worry about how the questions were asked. Additionally, like how do you ask things like education? How do you ask like race, ethnicity, or practice setting? We know that different people in different organizations ask things differently, and how you ask the question as you're analyzing your data may be different than how they ask their questions. And finally, as you think about your data, is it protected data? Is it public data? So you have to consider that as you're looking at your data set. So continuing with what to consider with data. So how are they presenting the data? Is it in rates per 1,000, per 100,000, per 10,000? You know, it's interesting because I've seen people try to combine data sets and find out that one place it's per 10,000, one place it's 100,000, it's not comparable. So you have to consider that. You also want to think about levels of geography. Is it at the census division, which is a number of states put together? It's at state level, county level, or sub-county level, because it does make a difference. And I'll go into some examples of how state or county versus sub-county may make a difference. And finally, as you're thinking about your secondary data set, are you reporting on the entire population if you're using a utilization data set, or is it a sample like a census data set or the American Community Survey? And we'll talk about each of these data sets. So again, as you're thinking about your secondary data set, you've got to consider a number of different things on what they mean. Again, I didn't necessarily want to spend a lot of time about cleaning secondary data because every data set's going to be a little different. But you need to consider things like, what do you do if you've got an incomplete response? What do you do if you have a non-response? Do you do data imputation to fill in the blank, so to speak? If the data is raw and it's not how you wanted to collect it, do you assign values? Do you create categories? For example, for age or years of service or even income, where you're getting raw data and you want to put it into smaller categories, 10 or 12 categories. Additionally, one of the things that we always look at is how do you combine response, especially around race ethnicity. So a lot of times people will ask race and ethnicity separate. Do you want to report them together? Do you want to report them separately? So rather than report white, black, and then Hispanic, you may want to report white, non-Hispanic, black, non-Hispanic, and Hispanic Latino. So there are a number of things you can do. And also when you get, the check all reply responses, how do you deal with that? So these are all things you really want to think about as you're coding and you're playing with your data. And finally, again, not to belabor the data cleaning point, does the data make sense? So as you start doing frequencies or crosstabs, are you getting information that doesn't make sense? An example I have, if you look at your RN data set and 50% are male, you've got a problem there. So again, I didn't want to belabor the point. So I want to go back to the data guide a little. At one point, we talked about in the data guide how to present the data in terms of basic analysis, intermediate analysis, and advanced analysis. So in this presentation, I'm going to give examples of basic and intermediate. But more interesting, or more importantly, is how do you tell the story? How do you talk about level of geography and develop your narrative, and also then use maps, tables, or graphs to kind of fill out your story and give people a fuller picture of what you're trying to do. And you all need to think about that as you are developing, again, the story you want to tell with your data. One of the things I want to talk about with level of geography, and there's a lot of research out there on it, it's how big or how small do you want to use your level of geography. So for example, if I'm looking at the number of physicians in Manhattan, if you look at the county as a whole, Manhattan, which is New York County, you're going to have plenty of physicians per capita for the whole population. But then at the sub-county level, where we've got shortages in the northern part of Manhattan and shortages in the southern part of Manhattan, again, looking at the county as a whole is going to mask information you may want to talk about. So again, consider geography as you're looking at your data. So I wanted to briefly talk about 4 data sources. And I know that some of these are very state-specific, and so I want to be as generic as possible, but I want to talk about licensure data, utilization data, census data, and then education data from iPads. And some of these, as we go through them, I'm going to talk about it in terms of some of these data has online queries you can use as well as data sets you can download, and then some of them have both public data sets and protected data sets, and I'll kind of go over some of the pluses and minuses to using each. Let's start with licensure data. The first question is, what healthcare occupations are licensed? I know in New York State, rad techs are not licensed. They actually are governed by the New York State Department of Health, whereas most of the other healthcare occupations are with the State Education Department. How many licenses are required? Again, for New York as an example, doctors license for the number of offices they have, so I could have 2 or 3 licenses for every doctor. NPs can be licensed in 1 of 16 certifications. So in both cases, we can have duplication. So you have to be careful about what you're looking at. How often is it collected? So licensure data for doctors and dentists are collected every 2 years in New York and for every 3 years for the rest of the occupations. And then finally, again, talking about public versus private data sets or protected data sets, what data is available? So if I go on to the State Education Department website, I can see name, license number, the city, and the zip code, and that's it. If I get the protected data set, I get the full address, I get licensing date information such as what their initial date of licensure as well as the most recent date of licensure, and I even get what college they graduated from for the most part, and we'll talk about that in a little bit. Other things to consider when you're talking about licensure data is practice information available. In New York, we do not know the specialty of the physician. We do know the specialty of the NPs. Are they actively practicing or not practicing? In this case, we don't know in our data set whether they're practicing or not. Again, as I talked about in the previous slide, the number of offices, and one of the things we find in many licensure databases and our own is it a home address or an office address? So what kind of demographic information is available? Sometimes you can get gender, age, race, ethnicity. Many times you cannot. So you've got to figure out whether that data set makes sense. And I wanted to specifically talk about level of education that's available and specific to RNs. So we know RNs can come in, if we're talking about basic RNs, as either an associate's degree or a bachelor's degree, and it's still in many states an RN diploma through a hospital. So all I know in New York State is what college they graduated from. So I don't necessarily know if it's a bachelor's or an associate's degree. We have many colleges, especially community colleges, that now offer both. Interestingly, with education in New York State, if you were licensed in another state first and then came back to New York State, they don't have their education in there. So there are a number of issues you have when you look at this data, these licensure data sets, and you need to be aware of it. So I wanted to, again, give kind of a brief display of data, both using basic analysis and intermediate analysis. And in this case, we're seeing some basic analysis, just counts of the professions in New York that actually are working in New York. We didn't include those that were licensed and had an address outside of New York. And as you can see, it's just basic counts. We don't tell you where they are. We don't tell you necessarily what they're doing. We did bring in population data from the American Community Survey, which we'll talk about in a little bit, and so we did some per capita. But again, very basic, doesn't really tell you much other than to give you kind of a start on the data. The next data set we started to do a little more with, and this is, again, where the education issue came in, where we broke it down by the type of school they went to. So SUNY is State University of New York. CUNY is actually just the colleges sponsored by New York City, and then private is basically anybody else. And as you can see, when you start talking about the NAs, those that we didn't have a lot on, 5,000 out of almost 43,000, we didn't have any educational information on. So as you can see, we're starting to talk a little more about what we're seeing, going a little more in depth, trying to understand the data a little more. And these are 5 different counties we looked at, both upstate and closer to New York City. Okay, so the next thing I want to talk about, we're going through these, and I want to leave some time for questions, because I think there are a lot of questions around. So let's talk about utilization a little. So what's included in utilization data? And I'm going to talk broadly about utilization, but we could talk about this in terms of claims data or in terms of hospitalization data, so I'm kind of going broadly on this. But does it include diagnosis? Primary and secondary diagnosis. In New York State, our hospitalization actually lists up to 24 additional secondary diagnoses. Procedures, again, how many? In New York State, we have in our hospitalization data 15. Insurance status and payer. So sometimes these data sets list just the primary insurance, other times they list primary and secondary insurance. So if you're talking about especially somebody on Medicare who may have Medicare as a primary and either Medicaid or some kind of secondary private insurance, that may be something you want to know. Also providers, what type of providers are listed? Again, as New York as an example, we actually list 3 providers, the attending, the provider who does the surgery, and another provider. So again, as you start thinking about what procedures a person's going through, what kind of care they're getting, you may want to get more information than just one provider, again, who the attending is. And then finally, as you think about utilization data, what kind of patient information is available? Age and gender, race, ethnicity. Is it, and we'll talk about this in a little, is it individual, is it categorized? It may be different depending on whether it's a public use data set or a protected data set, and even with diagnosis, and we'll talk about this in a little bit, but in New York State, diagnosis is categorized if it's a public data set. Again, with the issue of we don't want to necessarily identify the person, so we have to kind of strip out the data set as much as possible. So other things to consider when you're talking about utilization data. Is it population or sample data? Again, in New York, when we're talking about either Medicaid data or our hospitalization data, it is population data. It's the entire population. When you go to a federal data set, it's actually a sample. So you're not having everybody. At what geographic level? So some of the federal data sets, you can only break them down to the census divisions, which are an aggregations of states. So you got the Northeast, you got the Southeast, et cetera. As you look at your utilization data, is it a billing or a service location? We know that sometimes, especially with Medicaid data, as we look at the data, we find that the address listed is actually a billing address. So all of a sudden we have everybody who's getting ambulatory care at the hospital, even though we know that they may have 20 or 30 other sites around the county or around multiple counties. So you have to be concerned about that. Going back to kind of the provider issue that I talked about in the previous slide, is it possible to identify the actual provider? Do we have a list of providers? Do we have one provider? In New York, they talk about the provider who bills versus the provider who delivers the service, and it may be different. And additionally, can you identify the specialty of the provider? So as you look at physicians and NPs, do we know whether it's a primary care provider or if it's a specialty care? As you look at things like mental health services, dental services, they can be provided by primary care practitioners. So you have to understand that issue and how you're able to break those out. And in New York, it's very difficult. So we actually have to start thinking about linking to other data sets. Again, public versus private comes up here. And actually, I'm going to talk about public versus private and geography kind of in the same set. So the public data set for our Sparks data set, which is hospitalization, lists everybody in 3-digit zip codes. So 100, 120. So the example I always give is 120. And 120 covers where I was brought up, which is a very rural town in Schoharie County, if anybody needs to know that. 5,000 people, very rural, very isolated. Then 120 also includes the town or city of Coes, which is a small city with actually not very affluent, kind of poor. And then the third example is Clifton Park, also 120. Cobleskill is 12043, Cohoes is 12047, and Clifton Park is 12065. Clifton Park is very affluent. So when I start using this public data set, I'm mixing three very different populations, and it becomes very difficult to understand what they're doing and the differences. The last thing I want to talk about with utilization data is what selection criteria to use. And the example I have is actually ED visits in New York State. When an ED visit results in a hospitalization, we cannot pull that out as an ED visit. All of a sudden it gets combined with a hospitalization. So if you're thinking about looking at your ED use and you're missing that population of people who are using the services, what's it telling you? You're missing something. So you always have to kind of, what's in the data, what's not in the data, what selection criteria they use. Another example of selection criteria is when you're looking at diabetes. And I've seen it where they'll say when diabetes is the primary diagnosis. And sometimes they'll say all diagnosis. So not only are you taking the primary diagnosis, but you're looking at all the secondary diagnosis, which expands the population you're looking at. Again, so as you're thinking about these issues, what are you seeing and how are you seeing it? Again, I wanted to give a couple of examples of how we do basic analysis with our utilization data. And again, this is our Sparks data from 2014. It's our patient data. And as you can see, for the 5 counties and statewide, we just list the number of patient days and the percentage they relate to the total state. But it doesn't tell you anything. We don't know the populations of each of these counties. We don't know if they're overutilized, underutilized, or how it really, what story we're trying to tell. But again, it's a start. So let's kind of go a little more into depth. So the same data, now we've done a couple of things with it as we're talking about intermediate analysis. We've added two things. We've added years, so all of a sudden now we're looking across 5 years. And we've also done per capita. So we've taken the population of each of the counties from the American Community Survey, and all of a sudden we've applied it to the number of patient days. And so as you can see, all of a sudden now we're looking at trends, we're looking at comparison between the counties and among the years. And so you can start talking about a different story. Okay, so we've gone through 2 different data sets. I want to talk about a third one, and that's the American Community Survey. So it's collected by the Census Bureau, and it's collected each year, and it's collected, so we've got the decennial census, 2010, 2000, whatever. But every other year, there's also the American Community Survey that gets a portion of the population. So we know that the decennial census is everybody, but then the American Community Survey is a portion of the population. And what I want to do is focus on the American Community Survey. So the American Community Survey has 2 parts. It's got a household component and a population component. So most of the work that I think we do at the center, and probably you do, is really around the population. So I'm going to focus just on that data set. So the population data set is reported in 1-year increments, which is 1% of the sample, and 5-year increments, which is 5% of the population, so to speak. And as you can see, geography is a little different. I'll talk about that on the next slide. Now, interesting with this one, as well as the utilization data, it can be accessed through American Fact Finder, which is an online query, and through PUMS data, which is public use microdata sample data. So similarly, the utilization data in New York, we can do, there's actually an online query, as well as you can access additional data from getting record level data. So in going back to the ACS, again, it's with a query and with data. So what do you need to consider when you're using ACS data? So again, which is better to use, the American Fact Finder or PUMS data? So the American Fact Finder, you're not going to be able to do kind of the crosstabs, look at various things, but you also have better geography in terms of looking at the data. PUMS data, it's record level data, but you're more limited with geography, and we'll talk about that a little too. At what geographic level? So we've got 1-year estimates for ACS data and 5-year estimates. So one-year estimates are for any geography over 65,000. So in New York State, I believe that knocks out about 2/3 of our counties. So again, if I'm using the one-year estimate, it's very difficult to look at every county. But the 5-year estimate becomes, you know, so right now what's out is 2010 to 2014, with 2011 to 2015 being released very shortly. It's over 5 years, but it could mask something that happens in an individual year. So one of the things, I was working with a group of counties a couple of years ago and using this data, and we actually pulled out the unemployment rates. The problem was that in 2009 and 10, when we were looking at the unemployment rates a lot higher than it was in 14 because of changes. So that 5-year average actually masked the change, that trend that was happening. So you've got to be very careful about how you use this data, especially around the 1- and 5-year estimates. So again, as I talked about a number of slides ago, does it get to the question asked? So let's talk about level of education a little. And I'll use RNs as an example. So as an RN, you can go to school, get a bachelor's in science or biology, chemistry, whatever, and then decide to go back and get an associate's or a bachelor's in nursing. So what happens if you're looking at the highest education, which is how the ACS does it, then you're actually could be undercounting RN education because they may have a bachelor's in biology, but again, an undergraduate or associate's degree in nursing. Same thing with work setting. When we start looking at, especially for healthcare professionals, the number of their work settings, the ACS is much broader than you probably want. So for example, if I'm looking at hospitals and I want to know inpatient versus outpatient, I may not get that with ACS. Whereas if I do my own primary data collection, I'm going to ask specifically, are you hospital outpatient, hospital inpatient, as well as probably hospital ED to really understand where people are practicing. I wanted to talk a little about the advanced search for the American Community Survey or census data, just to give you an idea of kind of it's out there. So when you go into advanced search, it asks for level of geography. Again, national, state, county, sub-county. You can ask for zip code, census block, or census tract. Now be aware that depending on the data set, you may not get some of this sub-county information, so you got to be kind of aware of that issue, what year you got it and how they count it. And then you identify the topic, so you can identify people or housing or income, race, ethnicity. There are a number of different topics. So by putting these together, it actually comes out with these predefined reports that, again, give you a couple of answers, but doesn't necessarily kind of create crosstabs for the data. So if you want to look at race, ethnicity by job title or something, or job category, you wouldn't be able to do that. So again, there's some pluses. It's easy to access. You can get some real basic data. On the other hand, it limits the type of analysis you can do. So I wanted to go over, there are some standardized reports that the ACS has out that you can actually use, and I want to just briefly highlight them so that if you're just looking, again, for basic information, you print these reports out and you're good to go. So the first one is the DP1, and it's for the census, and it's 100%. So sex and age, race, ethnicity, and household relationship. It gives you some basics, but it doesn't give you a lot of additional information on your population. Whereas the American Community Survey starts getting into that information. So the DP2, which is a sample, again, if it's 1 year, it's 1%. If it's 5 years, it's 5%. And it starts going into the type of household, marital status, educational attainment, and citizenship. Additionally, they've got the DP 03, 04, and 05, and as you can see, again, different information. So 03 gives you employment status, household incomes, information below the federal poverty level, and it breaks it into a number of categories, 50%, 75%, 100%, et cetera. So again, you're starting to get a little more information, but again, it's only a sample. Selected housing characteristics, the number of rooms, the year structures are built, and the value of the house, and whether it's owner-occupied or not. You know, one of the things as I teach public health and I talk about year structures built, that's so important when you think about a lead poisoning, because we know that prior to 1978, there was lead in the paint. So as you're thinking about lead poisoning issues in the community, this may be one of those data indicators that you use. And then finally, DPO5, where it can count, it gives you estimates of sex and age, race and ethnicity, and other things. So again, you've got these standardized reports, but when you use the query, there are a ton of other data elements that you can pull up, and I just wanted to give you a flavor for a few of them. So here, again, so let's go back to basic analysis, and we'll do intermediate analysis. So here's one where I actually used the query, and I pulled out for 2 counties in New York State, Albany County and Allegheny County, population counts by race ethnicity. So this was from the 5-year estimates, the 10 to 14, and as you can see, it gives not only the counts, but because it is a sample, it's going to give you the margin of error. So you can start, again, talking about what the population looks like, again, over that 5-year period. And as you notice, that what I picked was actually Hispanic and Latino and non-Hispanic Latino broken out by race, so that I can talk about white non-Hispanic, black non-Hispanic. So the intermediate analysis we did, we started looking at using PUMS data. So the first one we used queries. The second one we actually looked at the PUMS data that we brought down on record level data. And what we looked at was the age of physicians, the percentage of physicians over 55, the percentage of physicians over 65. And we compared 4 different regions. So let me kind of go into this data, why we did certain things the way we did. So the way physicians are reported right now, there's not a lot of specialty information, so we don't know if they're primary care or if they're specialty care. Also, as I said with PUMS data before, it's reported by PUMA. And if you look at the North Country, to the right-hand side, that is actually 4 counties. There are 4 counties actually as one PUMA, so we couldn't break it out by county. If you look at New York State, or New York City, excuse me, multiple PUMAs make up 1 county. So depending on how you want to report the data, depending on what you're looking at, it's going to tell you different things. And as you can see, we're starting to make, in the North Country, as you can see, we've got an aging physician population that needs to be addressed. And also, I think Hudson, Capital District a little, not so much right now with the 65-year-olds, but the 55-year-olds and up, looks like it's going to be a big cohort coming through, so we need to, if we're going to plan for that area, we need to start thinking about that data. So the last data set I want to talk about is IPEDS. It's integrated post-secondary education data. It comes from colleges, universities, even BOCES reports some of their programs, and BOCES is the vocational programs in New York that train LPNs and other ones. So it's collected annually. Again, it can be accessed through summary tables, user-defined, as well as data sets. And there are 3 data sets, and we'll talk the importance of those data sets in a little bit, but institutional characteristics, 12-month enrollment, and completions. And completions you can get by degree type, which is defined by CIP, so RNs, pharmacists, doctors, et cetera. By award level, so as I talked about with RNs can be an associate degree, a bachelor's degree, or a master's degree, or something, so we actually break those out, and then by race, ethnicity, and by gender. But you also have to think about the data set. So as you use this data, be aware of a couple of things. The fields do change. Some fields are discontinued, some are added. Definitions change. The CPI codes have changed as different occupations have had different levels of education. And each school has multiple records corresponding to different programs. So one college could have hundreds and hundreds of records because they have different educational levels, master's program, bachelor's program for engineering, for nursing, for political science, whatever. So you get multiple levels. And if you're going to, and this is probably the most important thing, if you're going to link the other 2 files, I'll go back to those. If you're going to link the 12-month enrollment and completions, and you want to do that by educational program, a university or a 2-year college, or by geography, you need to link those files to the institutional characteristic files, which will give you, again, information about the county they're in, the type of university they are, and other characteristics that are important. So just be aware of that when you're using this file. So again, as I explained with some of the other data sets, there's an online query you can use, as well as you can download the data. So using the online query, we looked at the number of RN graduates per 100,000 in selected states, and we also compared it to the total population and created per capita. So we looked at zip code for 513801, which is RNs. We didn't break it down by degree, which we could have. And then we took 5 states throughout the nation and again, looked at their RN graduations as well as their per capita information. And as you can see, smaller states actually graduate more nurses per capita than larger states. But it doesn't tell you much else. So it really starts giving you some basic information again, but you're limited what you can do. So let's look at an intermediate analysis, and we actually started looking at race ethnicity for RN graduates by the selected states. Again, we had to combine the graduation data, which was the third file, with the first file to get the states. We looked at race ethnicity, and as you can see what our categories are. We could have done one state across years. We could have done one state with multiple professionals, again, RNs, doctors, physician assistants, nurse practitioners, whatever, to get kind of a fuller story. And this was just an example. Finally, and this was in the data guide, and our boss, Dean Moore, always talks about telling the story. And as I go out and talk about data sets, I always talk about how you tell the story. And I think for people who aren't researchers, trying to collect data from multiple places is difficult. How do you collect the data? What form are they in, and how do you do that? And us, as well as a number of other states, have done this, kind of telling the story, bringing multiple data sets together. So we did this data guide to kind of help people understand not only what professions we have currently, but what healthcare indicators may be telling us about what professions we may need. So I brought in diabetes information, I brought in behavioral information, I brought in demographic information and education information to, again, start telling that story about what we need in this county, or actually this was New York City, and how this information may relate to the need for our workforce. Again, what I wanted to do, and David did talk about this, what I wanted to do was give people a lot of ability to ask questions as much as possible to really start. Again, you know, to do something in 45 minutes with some of these data sets is very difficult because we could probably spend a couple hours on each of them. But this just gives you a kind of a broad handle on how they can be used, and then, you know, kind of for you to investigate further things. So let's open it up to questions.
Okay, thank you, Robert. That was very informative. And just a reminder to our audience, you may ask questions using the chat panel on your screen. Now, at this point in time, we already do have a few questions ready to go. In regards to PUMS data, Robert, at what level of geography can you get PUMS data at?
Well, actually, that's a good question. I kind of hit upon it a little when I was showing the data. But if you're using the query, again, depending on the data source, you can go state, county, sub-county, which would be a township or a city, and again, depending on the data source, even go to block group, zip code, and census tract. But if you're looking at the PUMS, the raw data, you can only use the PUMAs, and the PUMAs, again, are going to vary depending on the population. So again, in northern New York, I've got 4 counties that make one PUMA. So while I can kind of estimate things like population size, it's hard to break out race, ethnicity, education because it covers the 4 counties. But in places like New York City, where multiple PUMAs make up one county or one area, you can do that and look at county level data.
Thank you, Robert. Next question. What are the different processes in obtaining public versus protected data sets? Can you elaborate?
Sure. So I'm going to kind of give the New York State story since that's the one I'm most familiar with. But in New York State, there's a public data set that's available online, and as I said, they use the 3-digit zip code, 120, the example I gave before. They also categorize things like age, categorize diagnosis, so they're very broad. You can tell some things, but not enough. If you want record level data, you have to go through a Sparks request, and that actually is broken into 2 different levels. We've got limited data that's indirect identifiers such as city, state, zip code, and certain characteristics like race, ethnicity, age, and gender. And there's a process for that, and then there's more, a different process, or the same process with a little more intensity to it if you want identifiable data, which starts getting to the issue of when did the person go in, what was his or her admission date, his or her discharge date. You can actually also get other specifics around the patient information. So again, the secondary data or the record level data, you have to actually request the data, you have to justify it, and then explain why you need either limited data or you need the more expansive identifiable data. And even with that, there are a couple of things that they don't give you. So for both the very kind of politically sensitive data around abortions and around HIV, they don't give you any data. You just know that it's a record there, and it gives you less data, much less data.
And once more, can you give us some examples of protected data?
Date of birth, admission and discharge date, which I said, medical record number. Again, it's anything that identifies an individual. And it's also different depending on the county size. So if I'm looking at New York County, which is Manhattan, with a couple of million people, I can see gender, race, ethnicity, age of somebody. I probably would never be able to find them. If I go to Hamilton County with 4,000 people and I get the same information with a discharge date, I'm probably going to be able to identify that person. The best thing for kind of understanding what data is available is to look at your data sets and then also look at HIPAA requirements and try to understand how that works out.
Okay, thank you, Robert. And once more, for those of you in the audience, you may use the chat panel on your screen to ask questions. And just a reminder, we are recording this webinar, and it will be archived on our website at healthworkforceta.org in the near future. Okay, Robert, here's another question. Do you have some examples of some of the more advanced analysis that you or others have done? Maybe you can point us to some studies or reports that we can find online.
Can you clarify what you mean by advanced studies? In the data guide, we talked about advanced studies as modeling. So I don't know if you mean modeling, advanced in terms of modeling or other examples of analysis. So a number of people, and I'm going to pick out people just off the top of my head. I know South Carolina has done Tell the Story, where they pulled data out to do kind of a data guide like we have, that last example I gave. We have reports on how we do some data analysis around using ACS data. So the question was using other examples in using basic or intermediate statistics. Okay. So basically, if you look at the introduction to kind of data analysis, we talk about basic analysis as just counts. Could you count this? Could you count that? Could you just do frequencies? So it really is one variable at a snapshot in time. That's how we define basic. So how many nurses do you have? How many doctors do you have? What population is there? What's the breakdown of education by population? Those are all kind of real basic counts. More intermediate counts or intermediate analysis would be, again, multiple data elements either over time or over different, again, professions. So again, race, ethnicity by age, race, ethnicity by graduation, which was an example I gave. One of the things I like to look at is age breakdown by the type of occupation. Again, the physician example, we know in New York State that, and we actually did this with something we did 3 or 4 months ago, where we actually broke out for New York State using the American Community Survey, gender by the different healthcare professions, age by the different healthcare professions, race, ethnicity, and we also looked at citizenship status to start understanding our workforce, because we know in New York, and I don't know other states, so I really don't look at other states, but we know that we have an older healthcare population, workforce, and we've got to think about how that plays out as we're planning for the future. There are examples all over the place of these kind of analysis. Again, on our website, again, I don't use a lot of other websites in terms of states, but they're all out there. Again, think about it, basic and just frequencies, counts, intermediate analysis, think about multiple time periods, multiple variables, starting to get more in depth on the data you're using.
Thank you, Robert. And once more, in the health workforce analysis guide, we generally use the term basic, intermediate, and advanced just to kind of help. It's really a heuristic to help guide researchers of different levels of experience to resources that they can use. And really, the difference between basic, intermediate, and advanced, it's often blurred, obviously. With that said, here's another question, Robert. What do you know, well, excuse me, what do you do if you don't know if an address is a home address, an office address, a practice address, et cetera? I mean, how do you handle it?
You know, we've had difficulty understanding that because we know, for example, in New York City, where people are working outside of New York or living outside of New York City and commuting in. So we've got Long Island, we've got kind of the lower Hudson Valley, and we've got New Jersey and Connecticut. People are coming in there, they're licensed in New York as health professionals, and they're all over the place. Unfortunately, there's not much we can do about it. We highlight it usually when in our limitations, we'll highlight that we're using the address that's there, with the understanding that I think for some place like New York City and other cities, probably in New York as well as outside of New York, that migration's a huge issue. I think in rural counties you get less of an issue there. So you kind of just look at it and say, all right, here's a limitation, we understand the limitation, and we'll explain it. Again, this is a case where I think it tells part of the story, and better, data collection is needed. Better primary data collection is needed to really understand where your workforce is, where they live and where they practice.
Okay, thank you, Robert. And, well, I don't really see any more questions. And so if someone in the audience wants to go ahead and ask a question at this time, please do so. Otherwise, we'll go ahead and end a tad early. Just give you a moment to do that.
I have my phone number as well as my email address. So you can actually email me or call me with additional questions, not a problem. Oh, okay, that is, all right, David's gonna read a very good question.
Okay, as Robert says, I'm gonna read a very good question. Okay, when using the iPads to count RN completions, we have had trouble figuring out how to identify new RNs from existing RNs who are advancing their education. Do you have any insight into this problem?
No, there's no good way to do it, unfortunately. It depends on the institution. So in New York, we actually have some, what used to be community colleges that have 2- and 4-year degrees. So we could actually pull out that individual college and look at who's graduating in 2, because we know if it's a 2, it's an associate. If it's a 4, it's a BSN completer program. That's kind of easy. More difficult is where we've got some 4-year colleges that have generic BSNs, they come in and do the 4 years, or ones that have come in at, in year 3 and now are doing the BSN completers. There's really no way to tell that. We have struggled with that. Again, just no good way to do it. One of the things we do in our states, we actually have a survey of RN programs, and we actually ask them each year to identify in BSNs who's a generic BSN and who's a BSN completer. So we've tracked that over 15 years, I think. So we actually have a handle, but iPads won't do that for you.
Okay, thank you, Robert. And since I don't see any more questions, unless there's a quick follow-up, I believe we'll go ahead and end this event. Do you have anything else you'd like to add, Robert?
No, on that last question, if you want to see a copy of our survey, again, email us, And again, it's something we've done for a number of years.
Actually, our RN survey is online. In fact, at the Health Workforce Technical Assistance Center, healthworkforceta.org, under Resources, there is the State Health Workforce Data Collection Inventory. If you go to that site, we have information on what different states are collecting on health workforce, whether or not it's supply data, demand data, or education. We also have some examples of health workforce surveys. So yes, some of the New York surveys are online there, as well as some surveys from other states. And also, if you're going online, looking at the site, and you notice that your state's not listed, but you are collecting data, by all means, fill out our survey. It's right there on the site at the State Health Workforce Data Collection Survey. Let us know what you're doing. And if you have any surveys you'd be willing to share with us, we'd very much appreciate it. One of the main purposes of this inventory is to not only monitor all the health workforce studies being done in the country, but also to facilitate contact amongst like researchers so they can share their experiences and ideas with each other.
Just a thing, by the way, if you see our survey, we also have reports annual reports that we have up on our website that talk about, that use the RN data survey, so you can actually look at how we use it. Again, if you find our survey, find our reports, and then if you have questions, please call me.
Thank you, Robert.
Thank you.
And thank you and the audience for attending this event. We hope to see you again in the near future. Have a good afternoon. And thank you out there for attending our webinar. Just to let you know, we will be posting our slides shortly to our website. So if you want to download them, check back very quickly at healthworkforceta.org. We hope to see you again in the future. Thank you, and have a good day.